Yes, so last time we spoke about the throat and okay. Please, can you all see this? Can you all see the screen?
Yes, dog, we can.
Yeah, we can see, sir.
Okay, and you can see the slides being moving, right? Changing. You can see me changing the slides, right?
Yes, dog.
Yes, sir.
It's
Okay.
not
Yeah, pardon?
Yes, Doc. Yes,
I
Doc.
don't see the slide changing from my side. I can only see the throat and neck. Only that.
That's already changed.
It's changing now.
Okay.
Yes.
That's fine, yes. Yeah, so we all appreciated from our last lecture that when you talk about the throat, we are fully appreciating that we have the pharynx and then the larynx with its associated blood vessels, nerves, and then muscles as the major structure, as part of the major structures within the throat. And then the other ones are the various passages, talking of the esophagus or the pharynx, and then also the airway, the respiratory airways as well. We appreciated the whole anatomy of the throat. We also realized that the pharynx can be divided into the nasopharynx, the oropharynx, and then the laryngopharynx. And then we also appreciated where exactly the incision tube opens. So it's like there is a connection between the nose, between the ear, and then the throat. And then we said that the tonsils within the throat. And then we said there are 4 types of the tonsils: the palatine tonsil, the lingual, the tubal tonsils, and the adenoids, also known as the pharyngeal tonsils. And then we also appreciated a normal tonsil, and then we attempted to differentiate it from the abnormal tonsils. An abnormal tonsil is when a tonsil is inflamed. The inflammation can lead to a much bulging tonsil, which may sometimes even override the uvula. And then we also have the throat redness as well. And then sometimes you could have this whitish spot or these whitish exudates on the tonsils. And we also said that as far as the pathologies that can affect the pharynx can be infected, and then that could possibly lead to a possible adenoid enlargement or hypertrophy. And then we appreciated that it usually peaks at the age of 5, and an adenoid enlargement usually resolves by age 12. And then clinically, you can present with a nasal obstruction, a corneal obstruction, and some chronic respiratory inflammation, which will typically present as nasal discharge, a post-nasal drip, and cough. And then you could also have an enlargement of the cervical group of lymph nodes as well. And then we also appreciated some of by nasopharyngeal exams, and then we can go that extra mile and do a soft tissue x-ray of the neck, where we get to appreciate an enlarged adenoid shadow. So the treatment, basically, we deal with the inflammation and then the offending agents. Inflammation, we can do a steroid, we can do some analgesic. You can do an adenoidectomy as well. And some of the complications were also highlighted. We also did some of the indications for adenoidectomy, which is eventually the surgical management, and some of the contraindications and the complications to expect. Please restart with tonsillitis. No. Hello?
Hello, sir.
Hello.
Yeah.
No.
No. No.
No, Doc.
Okay, good. So we are going to start today's lecture on tonsillitis. Like I said, with respect to the various structures within the throat, the tonsils and the adenoids are very, very, very important structures just because of the main immune function that they serve. So usually the tonsils are part of the whole immune cascade that helps in the management of, or that helps in preventing or trying to allow the body to get rid of any organism or any other offending pathology that the system come into contact with. And some of these organisms can predispose the tonsils into an acute inflammation, into a recurrent inflammation, into a chronic inflammation. So we all know that the typical inflammation of the tonsils are basically tonsillitis. And the acute stage, usually lasting less than a week, is caused by the beta hemolytic type of streptococcus. Some other viral infection can also cause acute tonsillitis. We are talking of common influenza viruses. Other bacteria aside the beta hemolytic type that can cause tonsillitis are pneumococcus, the staphylococcus as well. It's usually disease of the childhood and adolescence. And then the mode of infection is usually when one comes into contact with droplets from the air of an infected person. And then this spread can be either through sneezing, through coughing, and then or any form of contact with an infected person. Clinically, they present with fever, usually the temperature more than 37.5, 38 degrees Celsius, and there is dysphagia as well as odynophagia. You should by now be able to differentiate between dysphagia and odynophagia. And there is also some form of sore throat and then runny nose. It is worthy of note that this discomfort on swallowing can or may also radiate to the ears because of the connection the throat has with the ear via the eustachian tube. And the signs, an inflamed tonsil, usually reddened in color with those exudates that we described the other time. And the tonsils are usually enlarged, reddened, sometimes the crisps contain parts of infected area, as stated earlier. And it should be way of note that, not all the types of acute tonsillitis would present the same, not all of them. It would definitely be dependent on the offending agent. So if it's from a streptococcus, you should be expecting, of course, your painful enlarged tonsillar lymph glands, the absence of signs suggestive of viral nasopharyngitis. So if it is typical of a bacteria, how do you call it, tonsillitis, that is from a pharyngitis, sorry. If it is from a streptococcus type or organism causing that tonsillitis, you are expected to have certain signs that are not viral in nature. Remember, a typical viral nasopharyngitis presents with the runny nose, cough, red eyes, sneezing. And sometimes there may not be any fever. But the typical tonsillitis coccus presents with a painful enlarged tonsillar lymph glands, absence of the signs of suggestive of viral nasopharyngitis. Usually, there's a whitish exudate at the back of the throat as well as whitish tonsillar exudate. So you are going to see that whitish kind of plaque or whitish miniature on the surface of the inflamed or enlarged tonsil. So there is also a sustained high-grade fever. And then there could be some occasional rash of scarlet fever. So the typical streptococcal pharyngitis or typical streptococcal tonsillitis. Remember, the tonsillitis is the tonsils and then the pharynx can be used interchangeably. And there's a possibility once one structure is affected, it can be extended to the other structure, that is the pharynx. Yes, so there is a painful enlarged tonsillar lymph glands, usually absence suggestive of a viral involvement, such as runny nose, cough, or red eyes. There's also this whitish exudate at the back of the throat, or usually on the enlarged or inflamed tonsil. And there is a sustained high-grade fever, as well as occasional rash or scarlet fever. Investigations, usually because of these rashes and then because of the tonsillar lymph gland involvement, we would quickly want to rule out leukemia, because the typical leukemia would also present with enlargement of the lymph glands around the cervical region, a typical leukemia. You may also want to do a throat swab for culture and sensitivity to be very, very sure as to what organism is causing this tonsillitis. And then usually monospot test, that is in the advanced stage, rule out glandular fever, because the glandular fever also typically presents as the painful swallowing, the feverishness, the whitish exudates at the back of the throat, usually either inflamed pharynx or inflamed tonsils or even both. So you want to do a quick monospot test to rule out the glandular fever. Treatment. Basically, you want to manage the signs and symptoms. So the typical sign of painful enlarged tonsillar lymph glands, you want to quickly do some analgesics to clear the pain. And antibiotics, usually the penicillin, the cyclosporins, and the macrolide groups to clear these offending agents. But the most sensitive antibiotic that can deal effectively with the streptococcus and the staphylococcus, usually the penicillins and the macrolides. And then we have the recurrence. They're supposed to be two, not three. So you have the recurrent tonsillitis. So this recurrent tonsillitis is when one constant has recurrent attacks of acute tonsillitis. You see, recurrent attacks of acute tonsillitis. You should be able to differentiate the acute tonsillitis from the recurrent tonsillitis in that the symptoms of acute tonsillitis, that's acute tonsillitis will usually have the tonsils returning to their original shape or size. But for a typical recurrent tonsillitis, the tonsils are usually irregular, they are large, they are inefficient, they are semi-fibrous masses, having accumulation of debris and bacteria that do not return to its original shape or size. So maybe you will see a child coming to your consulting room, you examine the child's throat, you realize that the child's throat, the tonsils are really big, they are really bulging. So you want to quickly confirm from the mother whether the child has been having any episode of repetitive or any episode of recurrent attack of acute tonsillitis. Should that be the case, the diagnosis is no longer an acute tonsillitis, but recurrent tonsillitis. And because of the recurrent nature of the tonsillitis, there could also be a chronic cervical lymph adenopathy, and then as well as a jugular digastric gland being involved, and often remains so even during the quiescent phase. So we have there is this particular gland, at the jugular digastric region. It's like the whole cervical group of lymph nodes. Assess them and see. Anytime that you are assessing a child, the child has fever, the child is coughing, the child has nasal congestion, please don't ever forget to examine the ear and the throat. The ear and the throat should always be examined anytime that a child presents with fever, sneezing, running nose, as well as poor feeding. In the case of the chronic tonsillitis, a typical tonsillitis or a typical inflammation of the tonsils would qualify to be chronic if the tonsils are larger for the patient's age. Last Saturday, I saw a child, the whole tonsils extremely bulging, and then it had almost covered the uvula. So you couldn't even appreciate the uvula. There are some that you would typically see a more deviated uvula, because if one of the tonsils, tonsils are found at both pillars. So if typically one of the tonsils are inflamed, you can see a shift or a deviation, towards towards the opposite end of the enlarged tonsil. So there is fluid or pus from the crypt on pressure on the palatopharyngeal fold. So like the moment, you attempt to press, especially that neck region around the palatopharyngeal fold, that is just beneath the chin, you will be able to appreciate, just in the mouth, not the chin, the mouth, the palatine, the soft type, the soft area. When you attempt to just, press it a bit, to apply a small pressure on it, that is where you would see this exudates, this passive fluid sometimes coming from the crypt of the enlarged tonsils. And the surface of the tonsil is usually ragged, and the crypts are very deep. There's congestion of the vessels of the palatopharyngeal and palatoglossal folds. And the deep cervical lymph nodes are also enlarged. So this criteria are used when we want to make a diagnosis of a chronic tonsillitis. Tonsils larger for the patient's age. There's a fluid or pus from the crypts. The surface of the tonsil is ragged and the crypts are deep. And there is also congestion of the vessels on the palatopharyngeal folds, as well as enlargement of the deep cervical lymph nodes. Yes, and then there could also be a condition we call peritonsillar abscess. That is when the whole tonsils, that is around the tonsils, when they become inflamed with the offending agent being bacteria in origin, such as the gas group of bacteria. That's a group A Streptococcus, the Streptococcus pyogenes, the Staph aureus, the Staph pyogenes, the Staph aureus, the Haemophilus influenza, as well as certain anaerobic bacteria. So the peritonsillar abscess is simply cellulitis of space just behind the tonsillar capsule, extending onto the soft palate, leading to an abscess. So this is like purely academic kind of diagnosis, because it is sometimes very difficult to differentiate acute tonsillitis from the recurrent tonsillitis, as well as chronic tonsillitis, and even the peritonsillar abscess. But one thing that you have to note is that you can use the age usually as one of the determinants in diagnosing a peritonsillar abscess. Remember that the typical tonsillitis usually affect children less than 9 or 10 years old. Typically, that is acute tonsillitis. But in the case of a peritonsillar abscess, also known as a quinsy, they are usually found among the 15 to 30-year age group. They usually present the same symptoms as acute tonsillitis. Talking of the fever, dehydration, sore throat, dysphagia, or odynophagia. You have the tonsils, they appear normal, or sometimes they appear swollen, edema of the soft palate, uvular deviation. So the uvular deviation, a typical chronic or recurrent tonsillitis could also present as such. You could have a trismus, that is as a result of the irritation or the reflex spasm of the medial pterygoid muscle, the pterygoid muscle. So the trismus. Sometimes you can even have a long jaw, usually that's a trismus. You can have a dysphonia, that is edema leading to failure to elevate the palate as a result of the vagus nerve involvement. You could also have a unilateral referred ear pain, as a result of that, where the tonsils are situated. And the fact that, you remember the facial nerve, the branches of the facial nerve, and the fact that there is a branch that supplies the buccal cavity. Yeah, so there is also certain branches that affect, the throat, the tonsils, and then the muscles of the throat, the soft palate, and as well as the hard palate. So you should be able to once again ascertain if there is this referred pain, from one branch of the facial nerve to the other structures. And there's also a cervical lymphadenine as well. So complications as pneumonia, secondary to spontaneous rupture of the abscess. So there are abscess, that's the peritonsil around the tonsil, not the tonsil itself, so around the tonsil. So this abscess around the tonsil can lead to operation pneumonia when there is a spontaneous rupture of this abscess. There could possibly be an airway obstruction. You remember the soft palate becomes extremely swollen if there is also a tonsillar enlargement. Then that means that the whole throat, the whole passage will be blocked. That can lead to airway obstruction. There could be a lateral dissection into the pharyngeal or carotid space, bacteremia, retropharyngeal abscess as well. So within the pharynx, the pharynx is like the throat, and then the pharynx, the larynx, the tonsils, the adenoids. Yeah, within that particular space, there are other infections that may arise, that may arise, and usually from a pharyngitis, usually from acute otitis media, mastoiditis, odontogenic infection, that is from the teeth. And then there could also be an acute suppurative parotitis, that is from the parotid gland. Treatments in that situation, that's if a peritonsillar abscess or quinsy is made, it is an emergency. So you quickly want to deal with the life-threatening signs where you will secure your airway. Sometimes these patients have to be treated, and if it is possible, you can quickly aspirate surgical drainage and your culture and sensitivity. We do a warm saline irrigation, and then you can start your IV penicillin-based antibiotics, usually for the next. Someone is serving us, so.
Elisha.
So you can do your penicillin antibiotics, because it is very sensitive to streptococcus as well as the S. pyogenes and then the Staph aureus. And you can also add metronidazole or clindamycin to it, especially when the culture and sensitivity is positive for bacteroides, one of those anaerobes. And one can consider a tonsillectomy after a second episode of a peritonsillar abscess. So once a second diagnosis or episode of a peritonsillar abscess is made, we can do a tonsillectomy. So the treatment, it is an emergency. You want to quickly secure your airway. You want to do, usually we don't do that culture and sensitivity. So usually warm saline irrigation, just to reduce the swelling a bit, and do your IV antibiotic, the penicillin plus and metronidazole, and then you may want to consider a tonsillectomy after the second episode. So these are the indications for tonsillectomy. Indications for tonsillectomy. There are about 9 indications for tonsillectomy and 5 contraindications for tonsillectomy. And we have 4 complications, 4 commonly identified complications of a tonsillectomy. So a tonsillectomy simply means that is a surgical removal of the tonsils, which is aimed at trying to prevent the system from acquiring acute tonsillitis, recurrent tonsillitis, chronic tonsillitis, and peritonsillar abscess, also known as quinsy. So for the indications, we have an absolute indication and a relative indication. An absolute indication where we would definitely consider a tonsillectomy is when there is airway obstruction or when there is a suspicious malignancy within the throat. Once this happens, It means that the patient is at a higher risk, of having a total airway being obstructed. So that can lead to oxygen deprivation and later to death. So you may quickly want to incise the tonsils just to make way, or just to make way for the airway in the throat. Other relative indications are recurrent tonsillitis. Recurrent tonsillitis. So recurrent tonsillitis is a relative indication, which is a tonsillectomy can or may be suggested. Recurrent sore throat and chronically enlarged irregular tonsils, enlarged regional, that's a jugular digastric lymph glands. They are all part of the cervical of lymph glands. And then history of quinsy, that's when one has when there's a second, usually the second episode of peritonsillar abscess, second episode of peritonsillar abscess. It's an indication.
So when you do your this thing, what did you see?
It's not all that severe.
It's moderate dehydration. That is moderate dehydration.
Michael.
Okay. Please, can you share what is moderate dehydration? Okay, let's continue. So we have the relative indications, like I said, a history of quinsy. That is when one has 2 episodes of peritonsillar abscess. It's a relative indication for tonsillectomy. When there is a recurrent otitis media with features of tonsillitis or pharyngitis, if tonsils are considered a toxic focus for other diseases. So if the tonsils are one of the determinants for other related cardiac or renal conditions, a tonsillectomy may be suggested. When there is a the beta hemolytic streptococcus or diphtheria carriers, and when there is a history of infectious mononucleosis, all these may indicate a possible tonsillectomy. But the absolute ones, where the moment it is identified, we would definitely have to do a tonsillectomy. It's when there is an airway obstruction, when there is a suspicious malignancy as well. Contraindications. You cannot do a tonsillectomy if you can't do a tonsillectomy if there's a history of poliomyelitis or diphtheria or influenza epidemic, because this can further spread the reason why you are taking off the tonsils. So this can cause the organism that causes the polio or the diphtheria or the influenza disease to further spread in the system. It can lead to septicemia or bacteremia. When there's a history of heart disease or acute rheumatic fever, you may quickly want to correct these conditions before you consider a tonsillectomy. A tonsillectomy may worsen the. And also when there is an acute stage of tonsillar infection, except peritonsillar abscess. So when you have a history of acute tonsillitis, but not a peritonsillar abscess, that one is a contraindication. And as a precautionary measures, when one is pregnant or when there's a blood ischeriasis, that is when the patient is prone to bleeding, excessive bleeding, when there is hematological malignancies around, when the patient is very, very prone to bleeding, you may want to quickly resolve that before you consider a tonsillectomy. The complications, there are 4. Hemorrhage, it could be early, within 24 hours, or delayed. That is once it is within 7 to 10 days. There could be sepsis, infection. They are introducing a new or a foreign agents to incise a swollen or an inflamed recurrent tonsils. There could be otitis media. That could be a distant spread of the organism causing the tonsillitis. Distant spread usually via the eustachian tube, otitis media. And there could also be a possible chest infection. Remember, we could have some of the organism being pushed into the chest. So that is about the tonsillectomy. So we have the retropharyngeal abscess. So I'm going to quickly go through the retropharyngeal